Welcome to Last Minute Lecture. This free chapter overview is designed to help students review and understand key concepts. These summaries supplement, not replace, the original textbook and may not be redistributed or resold. For complete coverage, always consult the official text. So, picture this. A healthy 35-year-old male walks right into your clinic.
Okay, pretty standard.
Right. He runs marathons. He's never smoked a single cigarette in his life, and he rarely even drinks alcohol.
Oh, a textbook picture of health.
Exactly. And his only complaint is this painless, firm lump on the side of his neck. He says he noticed it while shaving like 3 weeks ago.
Just the lump, nothing else.
Nothing. He feels completely fine. No fever, no night sweats, no fatigue, zero infectious symptoms. Now, maybe 10 or 15 years ago, a provider might have just, sent him home, told him to apply some warm compresses, take some ibuprofen, and see if it goes away.
Yeah, that used to be a really common approach.
But today, as an advanced practice nurse, your internal alarm bells need to be ringing immediately.
They absolutely have to be.
Because you are likely looking at the new classic presentation of HPV-related squamous cell carcinoma.
Which is terrifying, honestly.
It really is. So, welcome to a custom-tailored deep dive. If you are tuning in right now, you are likely an advanced practice nursing or nurse practitioner student. You're gearing up for boards, or maybe you're just getting ready to step into independent clinical practice.
And we are here to act as your personal one-on-one tutors today.
That's right. We are doing a comprehensive review of the inflammatory and infectious disorders of the nose, sinuses, mouth, and throat. Basically, we are pulling apart Chapter 24.
Right. And our mission for this deep dive is to really master the pathophysiology, the rigorous assessment strategies, and the differential diagnoses, plus the evidence-based management for these core ENT presentations.
Because you're going to see this stuff constantly, right?
Oh, absolutely. The primary care setting is just flooded with these exact complaints. Stuffy noses, sore throats, fiery lesions in the mouth.
Yeah, the bread and butter of primary care.
Exactly. But the true art, the critical competency for an APN, is not just recognizing a symptom. It's deploying really sharp clinical reasoning to separate the vast majority of those benign, self-limiting viral things from the subtle, hidden red flags.
The red flags that demand immediate intervention.
Right. And we are going to analyze all of this systematically today, basically moving anatomically from the anterior nasal passages straight down through the oral cavity and into the pharynx.
I always like to think about the head and neck as like an interconnected plumbing and security system.
Yeah.
It's the best way to conceptualize the pathology here.
I love that analogy. It's a closed, mucosal-lined continuum.
Yeah. So if you have severe inflammation at the front door, in the nasal passages.
The mechanical edema just acts like a clogged pipe.
Exactly. The pressure and the fluid inevitably back up into the reservoir tanks, which are your sinuses.
Right.
And when those stagnant fluids become infected, the systemic alarms get tripped.
Yeah.
Your security forces, which are the cervical lymph nodes, become fiercely engaged.
You really can't isolate a chief complaint in the head and neck. A failure in one quadrant almost always triggers a whole pathological cascade downstream.
So true. So let's start at that front door, the nasal passages. Specifically, let's talk about rhinitis.
Okay, let's dive into it. By definition, rhinitis is just the inflammation of the nasal mucosa.
Right.
But clinically, when that patient sits in front of you, you must immediately categorize their presentation into one of two fundamentally distinct pathophysiological buckets.
And those are allergic rhinitis, AR, and non-allergic rhinitis, or NA.
Exactly. And you have to make that distinction early because the treatment algorithms for these two conditions are totally different.
Because the underlying cellular mechanisms driving the inflammation are completely unrelated.
Spot on.
I see APN students struggle with this in clinic all the time because, patients universally just come in and say, my nose runs all the time.
They don't usually hand you the diagnosis.
No, they don't. So let's break down the cellular machinery of allergic rhinitis first, because this is an IgE-mediated type I hypersensitivity reaction.
Right, meaning it requires prior sensitization. The patient has to inhale an environmental antigen first, like pollen, dust mites, or pet dander.
And their immune system basically messes up, right?
Yeah, it inappropriately flags this completely harmless protein as a major threat. So it synthesizes these antigen-specific IgE antibodies.
Okay.
And those IgE molecules, they circulate and permanently bind to the surface receptors of mast cells.
Which are just hanging out densely within the nasal mucosa.
Exactly. They just sit there primed and waiting.
So what happens when the patient encounters that pollen again?
That's when the pathology activates. Upon re-exposure, the patient breathes in that specific allergen, and the antigen physically cross-links those IgE antibodies that are resting on the mast cell surface.
Oh, so the cross-linking is the actual trigger.
It's the biochemical trigger, yeah. It
There.
causes the mast cell to degranulate. It literally ruptures. And it releases this massive flood of preformed, highly active chemoinflammatory mediators directly into the surrounding tissue.
And the big one there is histamine.
Histamine is the most prominent, absolutely. But you also get an immediate synthesis of leukotrienes and prostaglandins.
Which just wreaks havoc locally.
It creates a localized chemical storm. You get rapid, profound vasodilation, radically increased capillary permeability, and smooth muscle contraction.
So the fluid is just leaking everywhere.
Yeah, fluid leaks from the intravascular space directly into the interstitial tissue of the nasal turbinates.
Causing that rapid, massive mechanical obstruction, the stuffy nose.
Exactly.
Now, when I'm taking a history, I always look for pruritus as the absolute hallmark differentiator for AR.
Yes, the itching is key.
Because of that massive localized histamine dump, patients with allergic rhinitis are just plagued by intense itching. Their nose itches, their eyes itch, their soft palate itches. Yeah. And if the patient entirely denies having any pruritus, I immediately start steering my clinical reasoning away from an IgE-mediated process.
Right, because without the itching, you're likely looking at nonallergic rhinitis, or NAR.
Exactly. Let's talk about NAR.
So NA is still a chronic non-infectious inflammatory process, but it completely lacks that IgE-mediated histamine dump.
Which perfectly explains why the pruritus is absent.
Exactly. And it's also why you don't see any systemic eosinophilia on their labs.
So what's actually causing the swelling in NR then?
The pathophysiology there is rooted in abnormal autonomic responsiveness and vasomotor dysfunction.
Okay, break that down for me.
Basically, the neural control of the vascular beds in the nasal mucosa becomes super hyperreactive. It triggers vascular engorgement and heavy glandular hypersecretion, but it's in response to nonspecific environmental irritants.
So the triggers are like mechanical or chemical, not true allergens.
Exactly. It could be a sudden shift in barometric pressure or a change in temperature.
Like stepping out into the cold winter air and your nose instantly runs?
Yes. Or inhaling strong odors like heavy perfume or tobacco smoke. Even profound hormonal fluctuations like the ones you see in pregnancy or menopause can cause those nasal vessels to dilate and leak.
That makes a lot of sense. Now, there are two very specific high-yield variants of NAR that providers frequently mismanage.
Oh, yes. These are crucial to recognize.
The first one is rhinitis medicamentosa. And this one is fascinating because it's purely iatrogenic, or basically patient-induced.
It's the afferent rebound.
Exactly. It's the direct result of using topical alpha-adrenergic agonist nasal decongestants like oxymetazoline or Afrin for more than 3 consecutive days.
Right. And what happens is the medication causes such profound vasoconstriction that the nasal tissue actually becomes severely ischemic. It's starved for blood flow.
And the tissue responds by downregulating its alpha-adrenergic receptors.
You got it. So when the patient finally tries to stop using the spray, those vessels, which are now starved of oxygen and completely lacking normal receptor tone, they undergo this massive, violent rebound vasodilation.
So the congestion comes back exponentially worse than it was when they started.
Way worse. And the patient gets thrust into this really vicious cycle. They require increasingly frequent doses of the spray just to achieve a baseline level of nasal patency.
And over time, the mucosa eventually just becomes fibrotic.
It does. It's really tough to break that cycle.
The other major variant of NAR to look out for is atrophic rhinitis.
Ah, yes.
This condition involves the progressive physical thinning and atrophy of both the nasal mucosa and the underlying turbinate bones.
It's a destructive process, and as that mucosal layer atrophies, the goblet cells and the ciliated epithelium are just destroyed.
Which means mucociliary clearance completely stops.
Right, the escalator stops working. And that stagnant environment allows for dense bacterial colonization.
The textbook notoriously points out Klebsiella ozona for this, right?
Yes, that's the classic pathogen associated with it.
And clinically, these patients present with debilitating nasal crusting, severe epistaxis, and this is the really distinct part, a super foul, purulent odor coming from the nares.
It's a very memorable clinical presentation once you've seen it.
So as we transition from the history to the physical assessment, the differential diagnosis here really relies heavily on visual inspection.
It does. Your eyes are your best tool here.
For allergic rhinitis, you are looking for that classic allergic salute.
Right, that horizontal crease across the lower third of the nose.
Yeah, from the patient chronically pushing the tip of their nose upward, just trying to relieve the itching and open the airway.
You'll also see allergic shiners.
The dark circles under the eyes.
Exactly. It's from venous pooling in the infraorbital region. And you might also spot Denny Morgan lines, which are these prominent symmetrical folds right under the lower eyelids.
But the definitive physical finding, the real money shot, is what you see when you actually visualize the internal nasal vault with your otoscope.
Absolutely. The turbinates in a patient with allergic rhinitis have a highly specific appearance.
Because the swelling is driven by fluid leaking out, not an active infection.
Right. It's massive interstitial fluid extravasation, not active hyperammonia. So the hypertrophied turbinates look intensely pale. They are boggy, and they often take on this bluish or pale pink hue.
They literally look like waterlogged sponges.
That's the perfect description. And you have to contrast that with the presentation of acute viral rhinitis, like the common cold.
Because with a virus, the turbinates look completely different.
Entirely different. In an active viral infection, the inflammatory response is driven by hyperperfusion because the body is trying to deliver white blood cells to the site of infection.
So they're going to be red.
Super red. The turbinates will be remarkably erythematous, totally engorged with blood, and highly friable.
Meaning they bleed easily if you touch them.
Exactly.
Okay, so clinical diagnosis based on history and that physical exam is standard practice. But there are cases that are just refractory to initial management, where you actually have to objectively identify the offending allergen.
Right, when the standard stuff just isn't working.
And for that, skin prick testing, or SPT, remains the gold standard diagnostic tool for AR.
It offers up to 80% sensitivity and specificity. It's great.
The allergist basically introduces minute quantities of suspected antigens into the epidermis and measures the resulting wheal and flare reaction after about 20 minutes.
Sounds simple enough.
It does, but I want to heavily explore the absolute contraindications for SPT here.
Yeah.
Because this is where a minor routine diagnostic procedure can instantly turn into a fatal primary care emergency.
This is a huge safety point for students.
You absolutely cannot perform an SPT on a patient with severe uncontrolled asthma or severe eczema.
Right, because that localized antigen exposure from the test can systematize really rapidly in a highly atopic individual.
And that could trigger a massive life-threatening asthma exacerbation or even full-blown anaphylaxis right there in the office.
Which is terrifying.
Yeah.
But more importantly, from a pharmacological standpoint, SPT is strictly contraindicated in patients actively taking beta blockers.
This is the pharmacology piece that people always forget. Break down why that's so dangerous.
Well, if a patient experiences anaphylaxis during the test, what is your first-line life-saving intervention?
Intramuscular epinephrine.
Exactly. And epinephrine works by stimulating both alpha and beta adrenergic receptors. That's what causes the vasoconstriction and the bronchodilation that saves their life.
Right.
But if the patient's beta receptors are currently blocked by their daily blood pressure medication,
then the administered epinemus is only going to stimulate the alpha receptors.
yes, you get this unopposed alpha stimulation, which can lead to paradoxical, fatal cardiovascular collapse.
Wow. So you administer the life-saving drug, and it actually makes things drastically worse.
It's a complete disaster. So you have to screen for beta blockers. Also, patients have to completely wash out all oral antihistamines for several days prior to the testing.
Because the medication will just suppress the localized histamine response rate.
Yeah, you'll just get a false negative wheel. The test will be useless.
So for those high-risk patients, the ones on beta blockers, the ones with brittle asthma, or the folks who physically just cannot stop taking their antihistamines because they're so miserable, what do we do?
You completely bypass the skin prick and you order a serum test for antigen-specific IgE.
It's just a simple blood draw.
Exactly. It lacks that immediate, highly sensitive, localized reaction of the skin prick, but it carries zero risk of inducing anaphylaxis.
And it's entirely unaffected by concomitant antihistamine use.
Right. You don't have to take them off their meds.
Awesome. Let's move into the management algorithms now. The pharmacotherapy ladder for allergic rhinitis is rigidly structured based on symptom severity and chronicity.
It is. You have to follow the steps.
So for mild or purely intermittent AR, the first-line therapy is a second-generation oral antihistamine, things like loratadine or cetirizine, or you could use a targeted intranasal antihistamine.
Notice what wasn't on that list.
Right. The text specifically dictates that first-generation antihistamines, like dichenhydramine, are absolutely no longer considered appropriate first-line agents.
The avoidance of first-generation antihistamines is rooted entirely in their pharmacokinetic profile and the severe adverse effects that come with it.
Because drugs like diphenhydramine are highly lipophilic, right?
Yes, they cross the blood-brain barrier with remarkable ease. And once they get into the central nervous system, they occupy H1 receptors and cause profound sedation.
You get that cognitive blunting, impaired motor performance.
It's basically like driving drunk for some people. And additionally, those first-generation agents exhibit significant muscarinic receptor antagonism.
The anticholinergic toxidrome.
Exactly. Severe dry mouth, blurred vision, tachycardia, and urinary retention.
And we really have to worry about that in the older adult populations.
Oh, massively. In older adults, those anticholinergic effects frequently trigger acute delirium, profound dizziness, and devastating falls.
Which is why we use the second-generation drugs now.
Right. Second-generation antihistamines were engineered with much lower lipid solubility.
They don't cross the blood-brain barrier nearly as much.
Barely at all. So you get potent peripheral H1 blockade without the central nervous system depression or that dangerous anticholinergic burden.
Okay, but what happens when a patient presents with moderate to severe symptoms? Or symptoms that are persistent, like every single day, rather than just intermittent?
In that case, second-generation oral antihistamines are simply not potent enough to control the inflammatory cascade.
Right. The algorithm shifts entirely at that point.
It does. The absolute gold standard first-line treatment becomes intranasal corticosteroids, or INCS.
Drugs like fluticasone or budesonide.
Exactly. They aggressively downregulate the mucosal inflammation at the genomic level. They are incredibly effective.
But this represents one of the most significant clinical hurdles in primary care.
Patient adherence.
Yes. If intranasal steroids are the undisputed gold standard for persistent AR, how do you actually manage the patient who just abandons the therapy? Because they don't experience that instant airway clearance they get from over-the-counter Afrin.
It's a huge issue. And honestly, patient adherence to INCS therapy usually fails, primarily because providers fail to adequately explain the pharmacodynamics of the medication.
You really have to utilize targeted patient education here.
You do. I always explain to my patients that their nasal mucosa is deeply inflamed. I use an analogy. I say it's analogous to a severe sprain in a joint, like a sprained ankle.
Oh, I like that.
And using an over-the-counter vasoconstrictor spray, like Afrin, is like tightly wrapping that sprained ankle with a compression bandage.
It forces the swelling down and gives instant mechanical relief.
Right. But it does absolutely nothing to heal the underlying tissue damage. And the swelling is going to return ferociously the moment that bandage comes off.
Whereas the intranasal corticosteroid is the definitive treatment that actually extinguishes the cellular fire and heals the sprain.
Exactly. However, because it works by altering protein synthesis within the inflammatory cells, it requires significant time to reach therapeutic efficacy.
It's not an instant fix.
No. You must explicitly set the expectation that while they might notice some minor improvement within a few days, maximal clinical effect requires up to 2 full weeks of continuous daily administration.
2 full weeks?
Yes. And if the patient understands that timeline up front, they are far less likely to just abandon the regimen on day 3 when their nose is still congested.
Setting expectations is everything.
It really is.
So let's look at what happens when that allergic or non-allergic rhinitis is left unmanaged. The mucosal edema doesn't just remain isolated to the anterior nares, right?
Unfortunately, no. The inflammation spreads posteriorly, creating profound mechanical obstruction.
And this is the perfect transition into the pathology of Rhinosinusitis.
Let's follow the plumbing.
Exactly. The critical anatomical bottleneck here is the osteomeatal complex. It's located right in the anterior ethmoid region.
And this complex basically serves as the common microscopic drainage pathway for the maxillary, frontal, and anterior ethmoid sinuses.
It functions exactly like a single narrow drain at the bottom of a massive bathtub.
That's the perfect way to visualize it. Under normal physiological conditions, the ciliated epithelium lining the sinuses is constantly sweeping a thin layer of protective mucus toward this tiny exit.
But when the mucosal tissue lining the osteomeatal complex becomes heavily edematous-like from unchecked rhinitis, the tissue swells inward.
And it physically occludes the drain.
So the drain is plugged, But the goblet cells within the sinus cavities are still continuously producing mucus.
Right, and that fluid has absolutely nowhere to go.
So the sinus cavities just become engorged?
They get engorged, the localized oxygen tension drops precipitously, and the environment transforms into this stagnant, hypoxic breeding ground.
Which is perfectly suited for microbial replication.
Exactly.
And this precise mechanism forces us to confront literally the most critical diagnostic challenge in primary care, differentiating acute viral rhinosinusitis, AVRS, from acute bacterial rhinosinusitis, ABRS.
This distinction right here is the absolute battleground for antibiotic stewardship.
It really is, because the pathophysiology dictates a staggering clinical reality. Greater than 95% of all acute rhinosinusitis cases are purely viral in etiology.
You really have to internalize that statistic as a student. More than 95% of the patients sitting in your exam room with excruciating facial pressure and thick nasal discharge are infected with the exact same ubiquitous respiratory viruses that cause the common cold.
Rhinovirus, adenovirus, parainfluenza.
Yes. The bacteria, specifically Streptococcus pneumonia, Haemophilus influenza, and Moraxilla catarrhalis, they are just opportunistic pathogens.
They only secondarily infect those stagnant hypoxic sinus cavities in a minuscule 0.5 to 2% of cases.
Right, and only after the viral infection has sufficiently paralyzed the mucociliary clearance mechanism and completely stripped the protective epithelium.
But the problem is the clinical presentation for both viral and bacterial etiologies is virtually identical, isn't it?
That's the challenge. The patient will present with purulent nasal drainage, severe nasal obstruction, and focal facial pain that worsens when they bend forward.
Usually that maxillary cheek pain that radiates down into the teeth, or that intense frontal forehead pain.
Exactly. And importantly, the textbook explicitly states that if a patient does not exhibit purulent nasal drainage, their presentation is inconsistent with acute rhinosinusitis, and you must broaden your differential.
Okay. But if both AVRS and ABRS present with green, purulent mucus and intense facial pressure, how do you clinically isolate the 2% of patients who actually require antibiotics?
You isolate them by strictly applying validated clinical timeline criteria.
The timeline is everything.
You absolutely cannot diagnose a bacterial infection based on the severity of the symptoms on day 3.
Okay, so what are the criteria?
You suspect ABRS only if the patient meets highly specific temporal patterns. The first pattern is persistent symptoms lasting for more than 10 consecutive days without any signs of clinical improvement.
Okay, so just sick and staying sick for over a week and a half.
Right. The second and more clinically distinct pattern is the double worsening or biphasic illness.
Walk me through that one.
This occurs when a patient contracts a typical viral upper respiratory infection. They experience a gradual improvement in their symptoms around day 5 or 6, and then they are suddenly struck by a severe acute exacerbation of symptoms.
Like a sudden spike in temperature or dramatically worsening facial pain.
Exactly. Or a massive influx of thick, purulent discharge, typically occurring after day 10.
Okay, so they get sick, they start to get better, and then boom, they crash again.
Yes. That secondary clinical crash is the hallmark sign that the opportunistic bacteria have successfully invaded that vulnerable, virus-damaged sinus tissue.
And throughout this whole assessment, you have to remain hypervigilant for red flag findings, right? Because the infection doesn't always stay in the sinus cavity.
No, it doesn't. The paranasal sinuses share remarkably thin, delicate, bony walls with the orbits of the eyes and the cranial vault.
So if the pathogen breaches those barriers,
you are no longer dealing with a simple sinus infection. You are managing a rapidly progressing, site or life-threatening emergency.
What are the red flags we're looking for?
If your patient presents with periorbital edema, diplopia, any alteration in their mental status, high fevers accompanied by neutral rigidity, or a physically displaced ocular globe.
If you see any of that, all outpatient management immediately ceases.
Instantly. You do not prescribe an oral antibiotic. You facilitate an immediate emergent transfer to the emergency department.
Because those findings strongly suggest orbital cellulitis, bacterial meningitis, or a catastrophic cavernous sinus thrombosis.
Exactly. You do not mess around with those.
Now, in the absence of those red flags, the diagnostic workup for uncomplicated acute rhinosinusitis is heavily restricted, right?
Very restricted. The guidelines are emphatic. The diagnosis is made entirely on clinical grounds.
So no routine plain film radiographs.
They are completely useless.
What about nasopharyngeal swabs? Patients always want to be swabbed.
Nasopharyngeal swabs are highly contraindicated.
Really? Why is that?
Because the anterior nares are densely populated with normal commensal flora. The swab will inevitably just culture whatever organism happens to be colonizing the vestibule.
Which has absolutely zero correlation with this specific pathogen trapped deep within the isolated sinus cavity.
Exactly. It's misleading data.
Okay, so what about imaging?
A non-contrast computed tomography, or CT scan, of the paranasal sinuses is the absolute gold standard imaging modality. But, and this is a huge but, it is strictly reserved for evaluating chronic rhinosinusitis, highly recurrent acute episodes, or when you strongly suspect anatomical anomalies or impending severe complications.
You do not order a CT for a standard acute sinus infection.
Never.
All right, let's talk about the evidence-based management algorithms. For AVRS, the viral cases, management is entirely supportive.
Purely supportive. You focus on symptom mitigation and facilitating mechanical drainage.
Analgesics for the facial pain, and high-volume nasal saline irrigation to manually flush out that thick mucin and inflammatory debris.
Yes, but there is a massive patient safety caveat regarding saline irrigation that we have to talk about.
Oh, the neti pot warning.
Yes. You must explicitly educate patients that they can only use commercially distilled water or tap water that has been rigorously boiled and subsequently cooled.
Because if they just use untreated tap water or well water,
they are at genuine risk of introducing Naegleria fowleri deep into the olfactory mucosal bed.
Which is the brain-eating amoeba.
Yes. It leads to fatal primary amoebic meningoencephalitis. It is rare, but it is catastrophic. And it's entirely preventable with good education.
Such a crucial point. Now, when the patient unequivocally meets the strict timeline criteria for ABRS, the bacterial infection, we initiate targeted antimicrobial therapy.
We do. For the adult population, the first-line agent is amoxicillin. It's dosed at 500 milligrams 3 times daily, or 875 milligrams twice daily.
But there are exceptions where we escalate therapy, right?
Right. If the patient presents with specific risk factors for resistant pneumococcal strains, like any systemic antibiotic use within the past month, age over 65, recent hospitalization, or an unusually severe presentation, you must escalate therapy to amoxicillin-clavulanate.
Known commercially as Augmentin.
Exactly. The clavulanate is a beta-lactamase inhibitor. It protects the amoxicillin from degradation by the enzymes produced by resistant H. influenza and M. catarrhalis.
And what if the patient has a documented true type hypersensitivity to penicillin?
Then doxycycline is the preferred alternative first-line agent.
Okay, it is equally important here to highlight the therapies that have been explicitly removed from the guidelines.
Yes, let's talk about what not to do.
Due to astronomical rates of pneumococcal resistance across the population, macrolides, specifically azithromycin, the ubiquitous Z-Pak and trimethoprim sulfamethoxazole, or Bactrim, are no longer recommended for the empiric treatment of ABRS.
They are completely off the table.
But this restriction sets up literally one of the most contentious interpersonal encounters in primary care.
I know exactly what you're going to say.
Right. A patient presents on day 4 of an illness. Their nasal discharge is bright green. They are miserable, and they aggressively demand a Z-Pak. They tell you, my mucus is green, which means it's bacterial, and a Z-Pak is the only thing that ever cures my sinus infections.
We've all had that patient.
How do you clinically de-escalate and educate this patient without them storming out of the clinic?
This scenario is the ultimate test of your advanced practice communication skills. You do not simply say no and walk out of the room.
Right, you have to validate their symptoms.
You validate their severe discomfort, but you must systematically dismantle the clinical mythology they are relying on.
How do you explain the green mucus?
I carefully explain that purulent, brightly colored green mucus is not a definitive marker of bacterial presence.
It's actually from their own immune system.
Exactly. When the body sends massive numbers of neutrophils to the nasal mucosa to eradicate the virus, those neutrophils deploy an enzyme called myeloperoxidase. And that enzyme is incredibly rich in iron.
Ah, iron.
So when millions of neutrophils die and degrade in the mucus, that iron-rich enzyme oxidizes and it literally turns the mucus green.
It's basically like rust.
Yes. It is a sign of a robust immune response to a virus, not a bacterial invasion.
That is such a great way to explain it to a patient.
And then I explain that azithromycin has absolutely no mechanism of action against viral particles. And frankly, due to massive community resistance, it likely wouldn't even kill the bacteria if they were present.
So prescribing that Z-Pak on day 4 offers zero therapeutic benefit.
None. But it guarantees the destruction of their healthy gastrointestinal microbiome and actively contributes to dangerous community-level antibiotic resistance.
You just have to hold the line with the evidence and focus heavily on aggressive symptomatic relief.
Exactly. You give them other tools to feel better.
All right, so when these severe sinus and nasal infections are really raging, the lymphatic system engages to drain the localized tissue, channeling all that inflammatory debris down into the cervical lymph nodes.
Which brings us perfectly to the assessment of neck masses.
Yes, and we are making a critical cognitive shift here. We are pivoting from managing localized, self-limiting inflammatory processes to the high-stakes responsibility of ruling out malignant neoplasms.
There is a core non-negotiable diagnostic axiom here that every advanced practice nurse must internalize.
What is it?
In the pediatric population, a newly discovered neck mass is overwhelmingly infectious or congenital in origin.
Okay.
However, in an adult patient, a persistent, newly identified neck mass must be considered malignant until definitive tissue pathology proves otherwise.
Wow. So your absolute baseline assumption dictating your entire diagnostic timeline must be cancer.
It has to be. You have to prove it's not cancer.
The epidemiology of these malignancies has undergone a radical, terrifying shift over the last 2 decades, hasn't it?
It really has. Historically, head and neck squamous cell carcinomas were inextricably linked to heavy, prolonged tobacco and alcohol consumption.
Predominantly affecting older males,
Yeah.
right? Like in their 60s or 70s.
Exactly. But as public health initiatives have successfully driven down smoking rates, those specific oral cavity cancers have decreased.
Which is great news.
It is, but we are simultaneously witnessing an explosive, alarming rise in oropharyngeal squamous cell carcinoma, specifically tumors localized to the base of the tongue and the tonsillar crypts.
And this new epidemic is driven almost entirely by the human papillomavirus.
Specifically, the highly oncogenic HPV-16 serotype.
And this is exactly like our patient from the intro. We are routinely seeing these devastating cancers present as asymptomatic neck masses in healthy males under the age of 50.
Guys who have absolutely zero history of tobacco use and minimal alcohol consumption.
So how exactly does a virus from like decades ago suddenly cause cancer in a healthy guy?
Right. To understand that, you have to look at the molecular pathophysiology. When the high-risk HPV-16 virus initially infects the basal epithelial cells of the oropharynx,
It just sits there.
well, the viral genome actually integrates directly into the host's DNA, and it begins continuously expressing these two highly destructive viral oncoproteins designated E6 and E7.
Okay, E6 and E7, what do they actually do to the cell?
Well, in a healthy human cell, the cell cycle is tightly regulated by crucial tumor suppressor proteins, primarily P53, which triggers apoptosis in damaged cells, and the retinoblastoma protein, RB, which halts uncontrolled cellular division.
They're basically the brakes of the cell.
Exactly. But the viral E6 oncoprotein specifically targets and degrades the host's P53, and the E7 oncoprotein violently binds to and inactivates RB.
So it destroys both primary braking systems simultaneously.
Yes. By destroying both brakes, the virus forces the host cell into a state of aberrant, relentless, uncontrolled division.
And that uncontrolled division leads to a compensatory cellular overexpression of a secondary regulatory gene called P16, right?
That's the key. Pathologists now rely heavily on P16 immunohistochemistry staining as the definitive, highly reliable biomarker to accurately diagnose HPV-positive squamous cell carcinoma.
It's the footprint the virus leaves behind.
Exactly.
So when you are actually performing the physical assessment and palpating the cervical lymph node chains, you must acutely recognize the red flag characteristics of a malignant mass.
You really have to feel the difference. An infectious or reactive lymph node is typically soft, highly mobile, and exquisitely tender to palpation.
And usually accompanied by systemic signs of infection, like a fever.
Right. Conversely, you must be highly suspicious of any mass that feels stony firm, is immovably fixed to the underlying deep fascial tissue, and is completely painless.
Measuring greater than 1.5 centimeters in diameter and persisting for more than 2 weeks in the total absence of any identifiable infectious symptoms.
Those are your massive red flags. You must also rigorously question the patient regarding subtle, easily overlooked symptoms of an occult primary tumor hiding somewhere in the aerodigestive tract.
Like unilateral ear pain.
Yes, unilateral ear pain is often referred pain from a lesion on the base of the tongue. Also look for progressive dysphagia, persistent hoarseness, or unexplained rapid weight loss.
If your assessment reveals a mass exhibiting any of these highly suspicious characteristics, the diagnostic pathway is urgent and rigidly defined.
No delays allowed. The initial step is to order a high-resolution CT or MRI of the neck with intravenous contrast.
And this advanced imaging is crucial, right? To map the anatomical extent of the soft tissue involvement.
Yes, and to evaluate the integrity of the surrounding vascular structures and identify any additional non-palpable necrotic nodes that might be hiding deep within the cervical chains.
But imaging doesn't give you a cellular diagnosis.
No. To achieve the definitive cellular diagnosis, a fine needle aspiration, or FNA, biopsy is the mandated procedure of choice.
And an FNA is highly accurate and can frequently be performed quickly in the outpatient setting under direct ultrasound guidance.
It's fantastic, but there is a massive caution here. It is absolutely critical that you explicitly warn against referring the patient for an open excisional surgical biopsy as the initial diagnostic step.
You do not just cut it out.
Never. Cutting blindly into a malignant cervical lymph node violently disrupts the encapsulated tumor architecture.
And it carries an unacceptably high risk of irreversibly seeding aggressive cancer cells directly into the previously pristine surrounding muscular and fascial planes.
You can turn a treatable cancer into an untreatable one just like that.
That is terrifying. Now, I want to clarify a very common clinical conundrum here, because the textbook explicitly notes that thyroid nodules are phenomenally prevalent. They are clinically detectable in up to 65% of the general population.
They are everywhere, and the overwhelming majority are entirely benign.
Right. So if incidental bumps on the thyroid are that common, how does the APN avoid triggering a massive cascade of expensive, anxiety-inducing contrast, CT scans, and ENT referrals for every single patient who presents with a subtle lump on their neck?
It's a great question. The clinical differentiation hinges entirely on precise anatomical localization during the physical exam.
Which then dictates two completely divergent diagnostic pathways.
Exactly. When you palpate the neck, you must have the patient swallow water.
Okay.
If the mass moves synchronously with the upward excursion of the trachea during deglution, during swallowing, it is physically embedded within the thyroid gland.
So it's a thyroid issue, not a lymph node issue.
Right. And for a localized thyroid nodule, the gold standard initial imaging modality is not a CT scan. It is a dedicated high-frequency thyroid ultrasound,
which is exquisitely sensitive for characterizing the internal architecture, the vascularity, and any microcalcifications to determine if an FNA is actually warranted.
Exactly. However, if the firm mass is located laterally in the jugulo-digastric chain, completely separate from the thyroid gland, and it remains stationary during swallowing,
then your clinical suspicion immediately defaults to metastatic squamous cell carcinoma or lymphoma.
Yes. And in that specific scenario, you completely bypass the ultrasound and proceed directly to the contrast-enhanced CT or MRI to evaluate the complex cervical lymph node chains.
Regardless of the pathway, managing a suspicious neck mass requires immediate interprofessional collaboration.
You cannot do this alone. You must secure an expedited referral to otolaryngology for a comprehensive fiber optic nasal endoscopy and laryngoscopy.
To visualize the hidden mucosal surfaces and locate the primary tumor driving the regional metastasis.
Exactly. They have the scopes to find the source.
Continuing our anatomical progression, we move past the lips and into the oral cavity to evaluate the mucosal lining and the tongue.
Moving right along.
We are assessing stomatitis, which is generalized mucosal inflammation, and glossitis, which refers specifically to inflammation of the tongue.
The oral mucosa is incredibly sensitive, and the etiologies of these painful lesions are wildly variable.
Your diagnostic accuracy here relies entirely on recognizing highly distinct visual presentations and linking them to the patient's history.
Let's systematically review the primary etiologies.
Let's do it. First up is the herpes simplex virus, or HSV.
So the pathophysiology of HSV begins with a highly symptomatic prodromal phase. The patient will report intense burning, tingling, or hyperesthesia in a specific focal area before anything is even visible.
And then within 24 hours, you get these clusters of small 1 to 2 millimeter fluid-filled vesicles erupting.
Right, and those delicate vesicles rapidly rupture, coalescing to form extremely painful, shallow, crusted ulcerations.
Typically on the vermilion border of the lips, or the heavily keratinized mucosa of the hard palate and gingiva.
Yes. Now, you must differentiate HSV from aphthostomatitis, which are commonly known as canker sores.
Canker sores are so common And they are completely non-viral, right?
Entirely non-viral. They are an immune-mediated inflammatory response, often triggered by localized trauma, severe stress, or nutritional deficiencies.
Visually, how do they look different from HSV?
They present as exquisitely painful, shallow, grayish-white ulcerations, but they are surrounded by a highly distinct, bright red, hyperemic inflammatory halo.
And location matters here, too.
Right, hugely. Unlike HSV, aphthous ulcers almost exclusively manifest on the non-keratinized, freely movable mucosa.
The places like the inner buccal lining, the labial mucosa, and the ventral surface of the tongue.
Exactly, the loose tissue.
The third major presentation is oral candidiasis, or thrush.
The classic fungal infection. This manifests as thick, creamy white cottage cheese-like plaques adhering tightly to the buccal mucosa, palate, and tongue.
And the definitive bedside diagnostic maneuver for this is the scrape test, right?
Yes, the scrape test is essential. If you gently apply pressure with a wooden tongue blade, these fungal pseudomembranes will physically scrape off,
revealing a fiery red, raw, and often bleeding mucosal base underneath.
Right. And this is the critical clinical differentiator because leukoplakia, which we will analyze shortly, is permanently fixed to the tissue and absolutely cannot be scraped away.
Good to know. Next on the list is Vincent's stomatitis, historically referred to as trench mouth.
Though the modern clinical term is necrotizing ulcerative gingivitis.
And this is a severe, rapidly progressive, destructive bacterial infection, right? Predominantly caused by invasive spirituates.
It's awful. The patient will present with sudden, agonizing gingival pain, profound halitosis, and the physical necrotic blunting and ulceration of the interdental papillae.
Those are the little triangular peaks of gum tissue between the teeth.
Exactly. Those peaks just necrose away, leaving craters that are typically covered in a thick, purulent, grayish, pseudomembranous exudate.
Wow. Finally, we must assess for parasitic glossitis, more commonly known as black hairy tongue.
Which is a terrifying name for patients to hear.
But despite the alarming nomenclature, it is not actually a parasitic infection, and it does not involve actual hair.
No, thankfully. It is typically a benign condition resulting from massive overgrowth of fungal organisms heavily mixed with chromogenic bacteria.
And this almost universally follows a prolonged course of broad-spectrum antibiotics, right?
Yeah. Basically, the normal desquamation process, the shedding of the tongue cells, is halted. This causes the tiny filiform papillae on the dorsal surface to radically hypertrophy and elongate.
And then those trapped chromogenic bacteria produce pigments that stain those elongated papillae,
creating a striking dark brown or black hair-like appearance right on the surface of the tongue.
Now, if the visual presentation is ambiguous, you can employ simple in-office diagnostics. If you strongly suspect HSV but require confirmation, you can perform a Zank smear.
Right, you aggressively scrape the base of a freshly ruptured vesicle and examine the cellular material under the microscope,
looking specifically for the presence of viral, multinucleated giant cells.
Exactly. And if the white plaques are suggestive of candida, performing a 10% potassium hydroxide, or KOH, prep on the scrapings will rapidly dissolve the human cellular material,
allowing you to clearly visualize the characteristic fungal pseudohyphae and budding yeast cells.
Regarding the management protocols outlined in the text, the primary clinical objective for severe stomatitis is often pure symptomatic relief.
Because the pain can be so profound that the patient entirely ceases oral intake, leading to rapid, dangerous dehydration.
So you provide topical analgesia using viscous lidocaine 2%, or you prescribe magic mouthwash,
which is a compounded suspension typically utilizing liquid antacids mixed with diphenhydramine to coat the lesions and provide localized anesthesia.
Right. Now, for targeted eradication, you deploy oral antivirals, such as valacyclovir or cyclovir, to inhibit viral DNA polymerase in HSV infections.
And for oral candidiasis, you utilize topical antifungals, prescribing nystatin swish-and-swallow suspensions or clotrimazole oral troches that dissolve slowly in the mouth, ensuring prolonged direct contact time with the fungal plaques.
I actually want to explore the pathophysiology of that candida infection a little more deeply here.
Oh, please do.
Because I conceptualized the oral mucosa as a highly sensitive canary in a coal mine for the patient's systemic immune status.
Okay, so if a completely healthy-looking patient with no obvious risk factors suddenly develops florid oral thrush, and you have confirmed they are not HIV positive and they are not actively undergoing cytotoxic chemotherapy, how does the APN explain the sudden emergence of this fungal pathogen?
The explanation requires a really deep understanding of the delicate ecological balance of the human microbiome.
Right, because Candida albicans is just a normal endogenous commensal organism.
It is. It permanently resides within the oral cavity of almost every healthy human. Under normal physiological conditions, it is entirely harmless.
Because its replication is fiercely suppressed by the billions of competing beneficial bacteria that heavily populate the oral mucosa.
Exactly. Those good bacteria consume the available nutrients and physically occupy the epithelial binding sites. They effectively starve and crowd out the candida.
But when an APN prescribes a heavy course of broad-spectrum antibiotics to treat, say, a severe sinus or respiratory infection,
that medication blindly annihilates the protective bacterial flora.
and the moment that competitive inhibition is eliminated,
The endogenous candida, which is completely immune to antibacterial drugs, seizes all that vast empty real estate and replicates wildly.
manifesting as the visible white plaques of thrush.
Exactly. And we observe the exact same pathological mechanism in asthma patients utilizing inhaled corticosteroids.
If the patient fails to aggressively rinse their mouth and spit after every single administration of their inhaler, the highly potent steroid residue coats the oropharynx.
And that locally suppresses the cellular immune response within the mucosal tissue, creating an artificial localized immunodeficiency.
Which provides the perfect, permissive environment for explosive fungal overgrowth.
That canary is screaming that the local protective environment has been completely compromised.
And that concept of vigilance leads us directly into evaluating oral cancer, the silent, potentially lethal lesion.
We just spent significant time differentiating various painful, fiery stomatitis presentations. Now, the APN must exercise extreme clinical caution to distinguish those painful, benign, inflammatory lesions from completely silent, deadly, premalignant architectural changes in the tissue.
The foundational concept driving this assessment is the identification of OPMD oral, potentially malignant disorders.
Right. As we previously discussed, over 90% of all oral cavity malignancies are squamous cell carcinomas.
And crucially, these cancers do not typically appear overnight as massive ulcerated tumors.
No, they undergo a slow, progressive architectural evolution, often originating as these visually identifiable OPMDs.
But your physical exam has to meticulously screen for two primary presentations.
The first is leukoplakia. Clinically, this presents as a distinct, asymptomatic white patch or plaque firmly adherent to the mucous membrane.
And the defining characteristic here is that, unlike the pseudomembranes of oral thrush, leukoplakia absolutely cannot be scraped off with a tongue blade.
It won't budge. It is physically integrated into the altered epithelial tissue. The rate of malignant transformation for leukoplakia is highly variable depending on the exact anatomical location and the degree of underlying cellular dysplasia. But certain lesions demonstrate a transformation rate approaching 36%.
Which is alarmingly high. But the second and far more concerning presentation is erythroplakia.
Yes. This manifests as a distinct, fiery red, velvety, non-ulcerated patch. Typically, it's completely flush with or slightly depressed below the surrounding mucosa.
And the clinical severity of erythroplakia cannot be overstated, right?
No, it can't. Upon surgical biopsy, up to 90% of true erythroplakia lesions are found to harbor severe cellular dysplasia, carcinoma in situ, or frankly, invasive squamous cell carcinoma.
90%. That is terrifying.
It is.
So let's put this into a high-stress clinical context for the students. A patient sits in your exam chair. You observe a distinct white patch on their inner buccal mucosa. How do you, utilizing only your physical assessment skills and clinical reasoning in that moment, differentiate between acute thrush, a completely benign irritation fibroma caused by chronic cheek biting, or a potentially lethal leukoplakia?
You deploy a highly systematic, stepwise physical exam. Your very first maneuver is the scrape test.
You grab the tongue blade.
Yep. You apply firm, sweeping pressure across the lesion with a wooden tongue blade. If the white material easily sloughs off, revealing an erythematous raw base, your differential immediately narrows to an overgrowth of candida.
Okay, thrush. But what if the lesion remains completely fixed and undisturbed by the blade?
Then you move to the second step, evaluating the surrounding environment for mechanical trauma. You carefully examine the patient's dentition.
What are you looking for?
Is the white plaque located perfectly flush against the occlusal bite line? Does the patient have a jagged, fractured molar directly adjacent to the lesion? Do they admit to a nervous habit of chronically chewing on the inside of their cheek?
Ah, so you're looking for a cause.
Right. If there is a clear mechanism of repetitive mechanical trauma, the lesion is highly likely to be a benign irritation fibroma. It's basically just a hyperkeratotic callus formed by the mucosa to protect itself.
But what if the white patch is firmly fixed, completely painless, and located in an area utterly devoid of any plausible mechanical friction?
Then your clinical suspicion for leukoplakia must instantly skyrocket. And that initiates a rigid, non-negotiable clinical timeline.
And that timeline is the absolute bedrock of priority setting in oral mucosal assessment. What is the rule?
The rule is absolute. Any unexplained oral mucosal lesion, whether it is an ulceration, a white plaque, or a red patch, that fails to demonstrate definitive clinical resolution within a strict 2 to 3 week window must be immediately referred to an oral surgeon or otolaryngologist for an incisional biopsy.
So you do not extend the observation period.
Yeah.
You don't say, let's just keep an eye on it and follow up in 3 months.
Absolutely not. The window is 2 to 3 weeks, and then you secure tissue pathology. No exceptions.
This rigid timeline really underscores the profound health promotion responsibilities resting on the shoulders of the APN.
It does. Because comprehensive dental access is just catastrophically poor in many underserved areas, the primary care nurse practitioner is frequently the sole healthcare professional conducting a thorough intraoral assessment.
You are the frontline defense. You must actively screen the high-risk zones, the lateral borders of the tongue, and the floor of the mouth.
And you must aggressively educate your patients on the deadly synergistic risks of combining tobacco use with heavy alcohol consumption.
The biochemistry of this synergy is devastating.
It really is. The ethanol in alcohol acts as a highly effective organic solvent, radically increasing the permeability of the oral mucosa.
And furthermore, alcohol is metabolized into acetaldehyde, right?
Yeah.
Which is a toxic compound that physically impairs the host cell's ability to repair DNA damage.
Exactly. So when a patient drinks alcohol and smokes simultaneously, the alcohol essentially dissolves the mucosal barrier, flooding the unprotected, genetically vulnerable cells with the massive concentrated load of potent carcinogens present in the tobacco smoke.
The cancer risk doesn't just double, it multiplies exponentially.
It's a lethal combination.
Let's transition to the very back of the throat to tackle our final major anatomical region, pharyngitis and tonsillitis.
Severe sore throat.
Yes. We are basically synthesizing everything we have just learned regarding the clinical differentiation of viral versus bacterial pathophysiologies to manage one of the single most...
Right. However, 10 to 20% of adult pharyngitis cases are caused by a highly aggressive bacterial pathogen. Group A, beta-hemolytic streptococcus, specifically Streptococcus pyogenes.
And the APN must maintain a profound clinical respect for S. pyogenes. It is not merely a localized nuisance causing a painful throat.
No, it is a highly dangerous pathogen.
Because of the M protein, right?
Exactly. The virulence of S. pyogenes is primarily driven by a unique structural component on its cell wall known as the M protein. And this M protein is an absolute master of immune evasion.
It actively repels phagocytosis by the host's macrophages, right?
It does, and it effectively blocks the activation of the complement pathway, allowing the bacteria to rapidly multiply and aggressively invade the tonsillar tissue.
But the true danger lies in the host's delayed immune response to that M protein.
Yes. When the patient's immune system finally successfully analyzes the pathogen and synthesizes massive amounts of targeted antibodies to destroy the M protein, those antibodies can exhibit a catastrophic flaw known as molecular mimicry.
This part is so wild. The three-dimensional structure of the M protein actually closely resembles the structure of the proteins found in the patient's own cardiac valves, myocardial tissue, and the basement membranes of their kidneys.
Right, so the newly formed antibodies become confused. They eradicate the strep bacteria, sure, but they continue circulating, misidentifying the patient's own vital organs as the invading pathogen.
And they launch a devastating cross-reactive autoimmune attack.
This specific destructive immunological cascade is the exact mechanism that causes the crippling, lifelong sequelae of acute rheumatic fever and post-streptococcal glomerulonephritis.
Preventing that catastrophic, irreversible heart valve damage is the primary clinical objective when we treat strep throat.
It is the whole reason we care so much about strep. However, the mandate for antibiotic stewardship means you absolutely cannot simply swab the throat of every single patient who complains of pain.
Right, you can't just swab everyone. You must rigorously apply established clinical decision tools, specifically the center criteria to determine who actually warrants testing.
Right. You are evaluating the patient for 4 highly predictive clinical indicators.
What are the 4?
First, A documented fever greater than 100.5 degrees Fahrenheit. Second, the visual presence of thick, purulent tonsillar exudates. Third, exquisitely tender anterior cervical lymphadenopathy.
And fourth, and perhaps most critically, the distinct absence of a cough.
Yes, the absence of cough is huge. If a patient presents with a severely painful throat, but is also exhibiting a prominent cough, severe rhinorrhea, or conjunctivitis,
then the pathophysiology is overwhelmingly pointing toward a widespread viral infection.
Exactly. And in that scenario, you explicitly do not test them for strep.
Because if you swab a patient with an obvious viral cold, you run a massive risk of picking up asymptomatic group A strep carrier status.
Right. The patient will test positive simply because the bacteria are harmlessly colonizing their throat,
leading you to erroneously prescribe a 10-day course of heavy antibiotics that will do absolutely nothing to cure their active viral infection?
It's terrible practice. Now, the clinical presentation of strep must be sharply contrasted with infectious mononucleosis, primarily caused by the Epstein-Barr virus, or EBV.
Right, because while strep throat typically hits with a sudden, aggressive onset of high fever and localized throat pain,
mono operates on a much slower, insidious timeline.
The patient will present with a gradual onset of profound, crushing, debilitating systemic fatigue that outlasts a typical viral cold by weeks.
And in terms of the physical assessment, while strep causes pronounced tenderness in the anterior cervical lymph nodes, mono classically triggers massive symmetric enlargement of the posterior cervical lymph node chains.
That's a great clinical pearl. Furthermore, the EBV systemicizes. It heavily infiltrates the reticuloendothelial system,
which frequently results in clinically detectable hepatosplenomegaly, a dangerously engorged liver and spleen.
So when a patient meets the strict center criteria for suspected S. pyogenes, the initial diagnostic step is performing a rapid antigen detection test, or rapid strep test, right in the clinic.
But the APN must clearly understand the statistical limitations of this test. The rapid strep test boasts exceptionally high specificity,
meaning that if the test results are positive, you can be extremely confident it is a true positive, and you initiate antibiotic therapy immediately.
Right. However, the test has lower sensitivity, meaning the false negative rate is clinically significant.
So if the rapid test is negative, but the patient's clinical presentation heavily suggests strep,
the gold standard protocol mandates that you secure a secondary swab and send it for a formal throat culture to definitively rule out the pathogen.
You can't just trust a negative rapid test if the clinical picture screams strep.
Exactly. For suspected mono, the diagnostic pathway relies on the monospot test, which detects the presence of the heterophile antibodies produced by the immune system in response to the EBV infection.
Let's talk about management. The protocols for these pharyngeal infections are highly specific and fraught with severe clinical pitfalls.
For a confirmed strep infection, the first-line therapy remains penicillin V or amoxicillin.
But the critical patient education piece here is the duration of therapy. The prescription is for a full 10 days.
Not 5 days when the pain subsides, not 7 days.
It requires a full 10 days of continuous suppressive antibiotic exposure to completely eradicate every trace of the organism and effectively prevent the subsequent autoimmune trigger that leads to rheumatic fever.
You have to make sure they finish the bottle. Now, if the pharyngitis is identified as gonococcal or chlamydial in origin, the treatment requires dual therapy.
An intramuscular injection of ceftriaxone coupled with oral azithromycin or doxycycline to ensure eradication.
Right. Now, the management of infectious mononucleosis is where the APN must exercise extreme caution. Mono is a viral infection, therefore management is entirely supportive,
focusing on profound rest, hydration, and NSAIDs for the severe pain and fever.
But there are two massive non-negotiable safety warnings that must be addressed with mono. First, you must absolutely avoid prescribing ampicillin or amoxicillin to any patient you even remotely suspect might have mono.
Because of the rash, right?
Yeah. Yes. If you administer those specific beta-lactams to a patient with an active EB infection, almost 100% of them will rapidly develop a severe, full-body, vividly pruritic maculopapular rash.
But it's important to note, this is not a true IgE-mediated anaphylactic allergy to penicillin. It is a complex, virus-specific immune reaction.
Exactly. However, it is almost always erroneously documented in the patient's chart as a catastrophic penicillin allergy, permanently and falsely restricting their access to crucial beta-lactam antibiotics for the rest of their life.
Such a huge error. And what's the second warning?
It's regarding the splenomegaly. The engorged spleen is incredibly fragile. The capsule is stretched thin.
So you must explicitly, emphatically warn the patient to completely avoid all heavy lifting, strenuous exertion, and any form of contact sports for at least 4 weeks.
Yes. Even minor blunt abdominal trauma can cause the fragile spleen to catastrophically rupture, leading to massive, potentially fatal internal hemorrhage.
And finally, as a critical wrap-up on tonsillitis complications, you must continually monitor for the development of a peritonsillar abscess.
Oh, this is a big one.
If your patient suddenly develops massive unilateral swelling of the soft palate that visibly deviates the uvula to the opposite side,
Combined with severe progressive dysphagia, trismus, which is an inability to physically open their jaw, and they begin drooling because they can no longer swallow their own saliva.
and then the infection has reached the tonsillar capsule and formed an abscess in the deep tissue spaces.
And this is an immediate emergent referral to otolaryngology for surgical incision, drainage, and intravenous antibiotics.
Okay, I have one final philosophical pushback regarding clinical reasoning in primary care. We just discussed the profound danger of rheumatic fever, right?
Mm-hmm.
And we established that we treat strep throat aggressively, specifically to protect the heart valves.
Yes.
However, the textbook clearly states that delaying the initiation of antibiotics for 48 hours while waiting for the results of a gold standard throat culture does not mathematically increase the patient's risk of developing rheumatic fever.
Right, because the immune cascade requires significantly more time to initiate.
So, if it is statistically safe to withhold therapy and wait for the definitive culture results, why do guidelines ever support treating a patient empirically on day one?
That is the ultimate test of advanced clinical decision-making. As an APN, you are constantly balancing the rigid rules of antibiotic stewardship against the nuanced, individualized risk factors of the complex human being sitting in front of you.
So context matters.
Heavily. Yes, waiting 48 hours is overwhelmingly safe for the general population, but the clinical risk matrix shifts dramatically based on context.
Like what kind of context?
If you are assessing a patient who meets all 4 center criteria, they have a 103-degree fever, massive purulent exudates, and severe cervical adenopathy, and they have a documented personal history of acute rheumatic fever in their childhood.
Oh, wow. So their heart valves are already damaged and uniquely primed for a catastrophic secondary attack.
Exactly. Or consider a patient who is significantly immunocompromised, or a scenario where the local public health department has declared an active, rampant Group A strep epidemic in your specific community.
In those highly specific, high-risk scenarios, the immediate, tangible benefit of initiating empiric therapy to rapidly halt the bacterial replication and ease the severe suffering outweighs the theoretical risk of potentially overprescribing while awaiting the culture confirmation.
Exactly. Exceptional APN practice is about treating the unique, high-risk patient in front of you, not blindly adhering to a rigid, generalized algorithm.
I absolutely love that distinction. Treat the patient, not just the flowchart.
Always.
And that brings us to the conclusion of our incredibly detailed deep dive into Chapter 24. As a final provocative thought for you to mull over as you prepare for your clinical rotations, we have spent the last hour dissecting how intimately interconnected this small anatomical region truly is.
It's all connected.
But consider how environmental macro factors are poised to completely disrupt these established pathways.
Like climate change.
Yes. With global climate change steadily increasing average temperatures, the geographical reach of pollen-producing plants is expanding, and the duration of the active allergy seasons is extending by weeks or even months.
Oh, that's going to have a massive impact.
Think about how that prolonged, relentless environmental antigen exposure might begin shifting massive populations of patients from mild, intermittent allergic rhinitis into chronic, severe, persistent mucosal inflammation.
If the plumbing stays clogged for months instead of weeks.
Exactly. How will that fundamentally alter the downstream epidemiology of the secondary bacterial sinus and pharyngeal infections we just discussed? The foundational presentations you learned today will likely look very different in the primary care clinic of tomorrow.
It's a sobering thought, but it's the reality of practice. The clinical stakes in the head and neck are incredibly high, but you have the assessment tools, the pathophysiological knowledge, and the clinical reasoning frameworks to handle it safely and effectively.
You absolutely do. Trust your deep understanding of the pathophysiology, meticulously execute your assessment skills, and never stop actively hunting for those red flags.
A warm thank you from the Last Minute Lecture team here at the Deep Dive for learning with us today.
Take a deep breath, review your notes, and trust your training. You've got this.